Vatsal PARIKH. Vatsal PARIKH is a very senior vitreoretinal surgeon from Mumbai. He has his own Drishti Eye and Retina Center over there, and he's almost 40 years into practice of vitreoretina, and he does it with a passion. And he's operated a lot of very, very difficult cases with a lot of ease. Let's go over and see his cases.
Good morning, Karobi. I thank you for inviting me to this course. Now, I'm just going to show some tricks of vitrectomy. Now, this patient has a injury, is a young boy about 12, and there's a macular pucker, and there's a bad chorioretinal scar here and inferiorly. This is the OCT, and you can see the tip of the membrane here, and this is the post-op OCT. Now, instead of doing complete vitrectomy, what I have done is just peel the membrane over the disc and up to this area, and this is 1 month post-op. The patient is better anatomically. Now, this is the video. This was the area where the membrane was lifted, so I'm lifting with end gripping forceps, and instead of doing extensive PVD, I've just restricted surgery to the posterior pole. And I operated similarly another patient of chorioretinitis scar outside the arcade with macular pucker, and done limited vitrectomy and pucker removal and limited vitreous detachment. And subsequently patient had phaco, and this is almost 8 years that patient is doing reasonably well, and maintain 6/9 vision. So just going over the posterior pole, lifting it, it will get lifted from the optic disc also. Gentle maneuvering, repeated maneuvering is important. If you pull too hard, you may create a break here. So just be gentle and be repetitive in action. And once this is lifted from the optic disc, I have done core vitrectomy without dissecting anything at the base or trying to induce PVD, because if you induce further PVD, you may traumatize the retina more. Anatomically, patient has done well. This is 1 month post-op only. So visual outcome, I don't know. Now these are 2-3 cases I wanted to show of myopic eyes with retinal detachment. This is pre-op and this is post-op. Now if you see the surgery, there's a lot of vitreous haze, vitreous floaters. So we do core vitrectomy. There's no obvious, you would assume that PVD has occurred since there's so much of vitreous which is here, opacities. There was an inferior detachment. You do base excision. Now after doing this, normally one would do PFCL or create a retinotomy if break is not seen, and finish the gas with oil or something. Now here you see there is extensive myopic staphyloma here at the posterior pole degeneration. So what I have done is that after this, put now vitreous is, lot of vitreous is out, and this is the picture. This is the detachment. So instead of stopping here, what I have done is injected Orocort or triamcinolone powder, and once you inject triamcinolone powder, you will see the vitreous schisis. Can you put off the light? I think it will be better. Can you put off the lights, please? So here at the macula there was some epiretinal membrane, and once I remove it, there's a edge of the vitreous schisis here, and you can see that that edge is got lifted. And entire posterior hyaloid to a great extent came. just with forceps and occasional use of cutter. Now this is translucent posterior hyaloid. I believe that there could be breaks, micro breaks at some of these areas where vitreous is firmly adherent and which could have led to retinal detachment. So using triamcinolone powder was a key in this patient to detect this. Otherwise, if one uses silicone oil, retina would remain attached, there would be inferior detachment shallow. And if one uses gas, then probably it would redetach. And one will end up with resurgeries and retinectomy and other things. So this posterior hyaloid or vitreous schisis was seen after injecting triamcinolone powder into the vitreous cavity, and I have used only C3F8 gas as tamponade. You can see again here. So then after removing this, it was regular FG endo laser. Now what I have observed is this patient, myopic patients, I think RP is abnormal. This patient on day 2 had inferior detachment, and I was thinking that we'll have to do buccal because this was only C3F8 gas with vitrectomy. But this settled without any surgery. So probably myopic eyes, the RP is not functioning well, and this was transudative or exudative detachment, and this is the final post-op vision result when retina was nicely attached. Now this is another case, again high myopic, inferior detachment. I had initially buckled thinking that there is no break, but buckle didn't work, so this was the vitrectomy which was done. And again same way, there is no obvious PVD here, only vitreous haze. So I did base excision, and at this stage what to do next. So I injected in this patient also. You see inferior detachment, there is no PVR, retina is smooth, there was no obvious break. One could use PFCL and settle this retina, but instead I have, now this is after triamcinolone. There was a little powder which was stuck here and something was coming, so I peeled that membrane, and this is the membrane edge or that posterior vitreous schisis. Now I'm injecting here triamcinolone. Now when you are removing it with flute needle, if there is a loose vitreous cortex, you'll get it something coming into the flute needle. So you start peeling there, and you see how entire posterior hyaloid gets detached, gradually. You need patience and perseverance because you might have to stage second time with orocort also. Now this patient had similar detachment in other eye in 2005, and I had not used orocort, and I had to do 2-3 surgeries to settle it. Just put off that phone. So this inferior detachment, again there was post-op which settled with time, and this is the final picture. Retina was nicely attached. So probably there is element of transudation also, and this is the last patient who had myopic detachment. And now after core vitrectomy, this looks here like regular detachment, mobile retina. You see for the whole, if you don't see, create a retinotomy or PFCL injection. But here again, as I showed you, I am injecting triamcinolone powder, and you'll see what is happening here. You see this entire posterior hyaloid is seen so well now, which was not visible earlier. So just a simple use of triamcinolone, I think in practically all patients will make the difference, in completing the vitreous surgery, removing the posterior hyaloid. Now what is important is here you feel this is all hyaloid, but there is retina behind, because this is a myopic eye, so retina is thin, so you have to be careful in cutting. So I am limiting dissection at the posterior pole only, and eventually you'll see that the behind is retina. I am able to lift this hyaloid all round. This behind, what you see here is retina here, and the hyaloid is here. So try to remove as much as possible without creating breaks. Breaks can occur, but all the patients what I have shown have done well with the surgery. This is operated just 3 days back. So I have yet to wait for the result. So basically what I am advocating is that one should use triamcinolone powder during vitrectomy, at least for detachment cases. It will show you what you never saw before. Thank you for your patient hearing.
Thank you, Vatsal. That was a real sort of basket of lovely cases that you did show us, and the possible complications which only a very experienced surgeon can do. There are any questions for Vatsal?
With the limited vitrectomy you showed, sir,
और ये चालू करो
what are the
मेरा,
chances that
इसका full
you
screen
can
कर देते
create
हैं ना?
tractional events in the periphery?
पता नहीं.
See, this is I think third patient I have done. So I don't find any adverse effect. Probably what happens is that these are inflamed eye. So rest of the vitreous is quite condensed, Because this is traumatic injury. Other patient was chorioretinitis scar. So till now,
Brightness
not much problem. Theoretically, yes. But what happens is that if you try to create PVD on table, you will definitely create breaks,
And the other thing is, once you leave a significant amount of vitreous, it quickly organizes and becomes more hazy.
I'll send you the photograph of the first patient who is following up for 8 years, It looks quite good.
Quite.
I'm not very big series, but limited experience.